Hi, this is Chadi from CVI 2019, Denver, Colorado. With me is Arnold Seto. He is from Long Beach, VA, and UC Irvine University. How are you, Don?
Hi, great.
So you're giving a talk later today or tomorrow about FFR. We know how to use it for practice, but there is no evidence now to use it post-PCI. Can you shed some light?
Yeah, I think the latest excitement in physiology is that these resting ratios have really taken off. I mean, ever since the publication of the defined flare study and IFR sweetheart studies from 2017, there's been a rapid uptake in the use of physiology. And actually the latest data from Philips suggests that their market data suggests that up to 69% of the intermediate lesions, the total addressable market, are actually getting measured with physiology now, which is a vast change from the 10% that we might have seen just a few years ago. And so, I like to say that imitation is the best form of flattery. And so, once we had IFR from Philips, now we have FDA approval for RFR from St. Jude, DFR from Boston Scientific, and of course the PDPA has always been with us. So I think that there is an increasing role and uptake on the resting ratios, maybe more than I even expected. And I think it's very exciting because we're going to be dealing with the discordances with FFR here and there, the discordances of course with angiography. Particular to your point though, in terms of the latest data, the defined PCI trial was presented at ACC, and it was 500 patients who had PCI and had blinded IFR pullback after the PCI. And this demonstrated that up to 24% of patients still had an IFR less than 0.89, even following what angiographically looked like a good result. I mean, these were done by all of our expert sites. Imaging was allowed, but only still used in about 15% of patients. But despite the use of optimal angiographic techniques and some imaging, we still had 24% of patients have ischemia after PCI. And they suggested that perhaps we could be doing better after PCI by screening for this ischemia, by measuring IFR post-PCI, and then focally stenting wherever that step-up was on the IFR pullback, or now RFR pullback.
So you recommend when this is in 24% of the population, you recommend pulling back, because sometimes it's either the stent is not well opposed or there is a tandem lesion somewhere.
Right, great point. They actually subgrouped the times when people had residual ischemia. It turns out it's about equally distributed. 1/3 was within the stent, 1/3 was proximal to the stent, 1/3 was distal to the stent. So in contrast to what you might think, just inadequate stent deployment, often there's just much more diffuse disease than you might have thought, or it's an extra lesion that was angiographically occult. So the exciting thing is that with an IFR pullback, you have much better resolution, point-by-point resolution along the length of the vessel, along with co-registration now. So you can identify exactly where that lesion is that you can't see angiographically and stent that. Often it's the most proximal lesion that looks very modest angiographically that has the most hemodynamic result. So I think the more we look, the more we find opportunities to improve our care. And certainly from the PCI standpoint, when 20% of patients have post-PCI residual angina, and ischemia, it's likely due to ischemia, and we could potentially identify it and treat it by measuring post-PCI, IFR, or FFR.
I had this question before, like you are doing intervention over the IFR wire. Do I need to recalibrate? How reliable is the wire?
Yeah, that's a great question. One of the annoyances of some of the wires is that when you disconnect it, you lose the equalization, and then you have to pull back and re-equalize and go back in. And that has improved markedly over the years with the modern wires. And some of the optical wires, for example, may be less likely to have this. The microcatheter shouldn't have that. And even the piezoelectric crystal wires, they have that happen most commonly on the connect, reconnect, or if the wire is taken out of the vessel and changed from body temperature to room temperature and then put back in. So my recommendation is, if you're going to do this, you work over the FFR wire, the pressure wire, and then reconnect it, take a measurement and a pullback. And you'll find that surprisingly, if you left the wire in the body and worked over it, that most of the time the drift isn't too bad. It's still, you'll still see up to 11% drift. 11% of patients will have that drift, but that means 89% of the time it didn't have as much drift as you might have expected. So with a simple PCI, simple non-bifurcation, non-complex PCI, when you do that pullback and drift check, on average, we find that 85 to 90% of the time, the drift is okay.
So do you recommend to be on the safe side, like when I'm done on intervening, to pull back, flush, connect, normalize, and go back in, or no?
No. I mean, that's what I mean. I mean, I've
Keep it just connected.
yeah, keep the same wire down there. Balloon, stent, work over that wire.
Connect
and
back.
and then connect back, and then do that full pullback. You'll still see some step-ups potentially, and those are always good anyway. And even if the equalization is a little off at the end, as long as it's within 0.03, then it's going to be okay. And if it is greater than 0.03, well, you might want to remeasure it anyway.
Yeah.
So I think that happens a lot less than I might have expected now with the modern wires and with working quickly through the PCI.
That's
Again,
great.
if you've been working there for an hour, that's going to be drifting no matter what.
Exactly.
We measure drift in terms of millimeters of mercury per minute, and so the longer you take with that wire, then potentially the more drift.
More drift you're going to have.
Yeah.
Exactly. Well, this is very useful tips and definitely practical for the practice. That will prevent us also to have the patient have optimal medical therapy at the end of the PCI. Thanks so much, Don, for your time. Really a pleasure to talk to you. Please watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thank you.
Thank you for the opportunity.
Yeah.